My name is Noel de Miranda. I'm a researcher at Leiden University Medical Center in the Netherlands. I actually have an interesting story with FIGHT CRC. Actually, the first grant I got to be able to do research in immuno-oncology came from FIGHT CRC together with AACR. So congratulations to everyone that organized this meeting. I think it's really great. I put together with Dr. Overman a few questions that are still open in my mind and that could serve as a basis for the discussion, and to go forward in the field of immuno-oncology, specifically for early onset CRC. Although a lot of the things we'll discuss, I think they're applicable also to other CRC patients. Michael, do you want to add something, or should I just carry on?
No, I think that sounds good. Yeah, why don't you go ahead? No, sorry, I'm at an airport, and I
no worries. Okay, I'll take it.
So there's going to be some background noise on my side, so I
no worries.
Everyone already.
You're good. So as we heard earlier, there's currently a subgroup of CRC patients and early onset patients in particular that can benefit from immuno-oncology, and more specifically from checkpoint blockade therapy. And those are the patients that are classified as MSE high or mismatch repair deficient, but also patients presenting with molecular alterations in the polymerase gene, POLE or POLD1. So these patients benefit significantly from the usage of either antibodies targeting the PD-1 molecule or CTLA-4 molecule, and the objective response rates can range from 30% to 50% of patients. So related to this subgroup of patients, we came up with a few questions that we think are specifically interesting for this group. So the first one, and I think that's in the mind of a lot of us, is whether early onset patients will respond similarly to the general population of CRC patients. And I guess it might even be the case that early onset CRC patients might even respond better if you take into account features like immune senescence. In principle, the immune system for early onset patients might be more fit to respond to these checkpoint blockade therapies. And another question relates to the fact that, of course, we don't observe responses in all patients that are MSE high or that have POLE mutations. So we still lack knowledge on knowing what are the determinants of response. So which factors influence whether some patients respond or not. The majority of them has a high mutation burden. So there should be other factors beyond that very important factor for response to checkpoint blockade. And finally, whether we can find some evidence that guides a rationale for choosing giving a treatment with a single agent of checkpoint blockade or a combined treatment. Dr. Overman also referred to this in the previous section. There have been some very interesting preliminary data. So that the previous data I showed was in an advanced metastatic setting, so with distant metastasis. There's been some very interesting data coming from the neoadjuvant use of checkpoint blockade at earlier stages. So this is a paper from some colleagues at the Dutch Cancer Institute, where they applied checkpoint blockade therapy in colorectal cancer patients without distant metastasis. And here, for the mismatch repair deficient or the MSE high, they actually saw responses in all the patients that were included in the trial, and complete responses in a large proportion of patients that were included in the trial. And what is really striking as well was that a number of patients that were diagnosed with the mismatch repair proficient tumors, so the ones that are not responsive in an advanced setting, they also observed responses in a proportion of those, which is really exciting. and tells us that most likely in the near future we'll be able to apply immunotherapy to a greater number of patients. So there are a few questions that arise after these observations. And one of them, of course, we will have to show that neoadjuvant treatment with immune checkpoint blockade in the non-metastatic setting is indeed superior to the current standard of care. And here again, what is determining the sensitivity to immune checkpoint blockade between metastatic and non-metastatic settings? Why are mismatch repair proficient tumors not responding in the case of distant metastasis while they do respond at earlier stages of tumor progression? And Dr. Overman also really stressed this. The large majority of colorectal cancer patients, including early onset or early age onset colorectal cancer patients, are microsatellite stable and are currently not eligible to the majority of immunotherapies that are available. But there are very promising signs that in the near future we'll be able to come up with immunotherapeutic strategies that might benefit these patients. And some of these signs include the fact that it is now more or less accepted in the field of immuno-oncology that despite the fact that these patients have low numbers of mutations in the genomes of their cancers, there is evidence that the immune system in these patients is being able to mount immune responses. So we can detect T cells in these microsatellite stable patients that are recognizing antigens, so proteins that are being expressed in cancer cells, which means that in principle it would be possible to develop an immunotherapeutic strategy for those. And this is the question that I've came up with regarding this. So how can we harness the potential of cancer-specific T cells in MSS colorectal cancers? Apparently, this seems to be a bit more difficult when targeting PD-1 or CTLA-4 checkpoints. But there should be a way by which we can make use of this potential that is in the immune system of patients diagnosed with CRC. And finally, and this was also discussed during the previous session, there are very interesting possibilities to make use of combination therapy approaches for early onset CRC patients that also make use of immunotherapy. And we can think of standard radio or chemotherapy, but also other approaches like oncolytic virus to trigger inflammatory responses in patients, or vaccination approaches, for instance, that make use of proteins that are found in tumor cells. And finally, I mean, the field really hit a jackpot when starting to develop therapies against checkpoint blockade axis, and namely with a blocking of the PD-1, PD-L1 axis. But there are a number of other pathways and checkpoints that the immune system makes use of to control immune responses, and which might be very useful in the future to expand the applicability of immunotherapy to colorectal cancer patients. So this is a brief introduction to some of the questions that came to our mind regarding how the field should move forward, but it would be great now to open the discussion and see whether people have other ideas or questions that we might be able to answer.
Yeah, Noah, I might just say a few kind of just big comments, and there were a few questions that came in that I can address because I was reading the chat.
Yeah, that'd be great.
Yeah, no, I think, so in the deficient mismatch repair space, clearly that's where we have activity, and, there it's kind of how do you further optimize that, right? And so dual kind of immune therapy checkpoint has impressive activity. We have mono PD-1 based therapy, and when you do kind of combination or mono is a discussion we also have with patients. It appears that combo works better than mono in a cross trial comparison setting, but there's clearly more toxicity. So that's kind of the thing where, I think there was a question about the atomic study, which is the adjuvant MSI high of chemo plus atezolizumab, a PD-L1 versus chemo. And so the idea of, moving immune therapy earlier into, earlier lines where you actually have more patients, there's, more patients have MSI in localized settings. And so the ATOMIC study is still not completely enrolled yet, but it's coming up. The predictions are kind of end of this year, beginning of next year. But then there is a long period of time for events or readout that happen. So final results from ATOMIC is likely going to be well after it completes enrollment. So we're still probably years away from getting a result from ATOMIC. I think one of the big interests I have is neoadjuvant, just because you don't, ATOMIC's, one of the challenges with ATOMIC is chemo plus immune therapy, right? And I would kind of that I would like an immune therapy alone kind of approach. And I think in the neoadjuvant setting, you can give therapy and then assess your tumor response, endoscopically or various different ways. And so you can kind of get that assessment and see if all you need is immune therapy, right? Which I think my sense is the vast majority of these patients probably just need immune therapy. And I think the data is kind of clear that in localized, it appears to work better than in the metastatic setting. I think Noel showed some of that data, but there is this, the ability to become metastatic. There's kind of evasion that ends at that point. And I think it just makes our immune therapies tougher. And so when tumors are more not yet, obtained or had all these immune escape mechanisms in play, we can seem to kind of work better. And so I think that, along with that idea of the ATOMIC is moving things earlier. And then I think related to selection within MSI high. And, there's been some data that RAS mutation might correlate with lack of response, and I think and there's some sense that maybe less benefit. I don't think no benefit, but maybe less benefit a little bit. But I don't think there's any real black and white factors that we've delineated in MSI high to really help us. There's, the ones that are probably the two biggest, I think, out there are one, verify that it really, so that sometimes you have to actually have a loss of expression, but it may be not read properly by. So there is this question, do you really have a verified MSI high tumor? And for me, usually that means you have lots of mutations. And then the second one is the higher mutation appears to correlate with better response. But there's kind of a gradation there, and we don't have really a cut point on selection. Clean selection factors out there in the MSI space. And then, I think those were kind of the questions that I saw. I think MSS is, Noel's done fantastic work there about, finding you need immune system to recognize the tumor as, one fundamental aspect. And then you need to address all the immune suppressive factors that are kind of clearly involved in colon cancer. So, there's no doubt that there's immune suppressive factors that are playing a role aside from not just identification of tumor. And I think that's where, there's a lot to try to, identify and figure out those factors in those two different spaces. I would kind of put it a little bit. And I'll stop there. I think other questions come in, Noel, or should we just open up for people to ask questions, I guess?
Yeah. In the meantime, I do have a question for you. Have you seen, I don't know if we have enough data already for you to be able to give a good answer. So, as you know, MSI high cases, they have metastatic patterns which are slightly different or very different from the microsatellite stable. Do you see differences in the response to checkpoint blockade of mismatch repair deficient cases that end up in the liver with ones that end up elsewhere? Because in terms of microenvironment, it's very different as well.
Yeah, no, I think there's some, kind of intrigue from microsatellite stable, right? Where there's some therapy combinations with low rate of activity, but clearly if you select out maybe the patients without liver mets, you see an increase in activity, right? So I think there is some data in the microsatellite stable space that location of metastasis and liver met area you look at some of these, there's a number of combinations out there of PD-1 and a VEGF TKI, so regorafenib, apatinib, lenvatinib. And if you look at some of those studies, I've looked at this, you take out the patients with liver mets, the response rates and activity go up, so it does appear to be, there is a player of, where it is that site does matter, in microsatellite instability high, haven't really seen that correlation, I would say. I think they're just such a unique and different type of tumor. You have just so many mutations, so much immune recognition that doesn't appear to be a factor that we've seen in regards to kind of the base with PD-1 based therapy.
They're very obvious to the immune system, right? So the niche trial has focused specifically on colon, and I know now they're progressing now to do some more studies in rectal cancer. Are you aware of any studies in the neoadjuvant setting now that have focused on rectal cancer in combination with radio and chemotherapy?
Yeah, so I think there are some, prelim data. The niche trial was the first trial, and dramatic, right? We can talk about the microsatellite stable cases, but the MSI high, the response rate was 100%, right? It's it's really 20 patients, but just dramatic.
I've seen those tissues; it's unbelievable.
Yeah, it's. So Memorial Sloan Kettering has a rectal MSI high study where they're looking at immune therapy and kind of the combination of neoadjuvant therapy. That's ongoing and rolling. We did have a phase 2 study where we looked at pembrolizumab neoadjuvant for MSI high tumors, and we put an abstract at this past ASCO meeting in 35 patients, kind of tumor agnostic, at a number of different tumor types, and really saw similar to the niche trial, just really high activity level. It's phase 2 study, but our response rate was up kind of 70-80% range. And then a luminal response, if you give therapy, go in and look at the colon primary or the rectal primary, the luminal response rate was like, almost 90%, so really kind of suggesting that I think, it does appear to work better in the non-metastatic space. That the niche trial and then our study, I think both kind of validate that phenomenon. And I think, that looks really great. Just, we're seeing small numbers and kind of, 2 different studies I'm quoting, and those are, I think, the only studies out there besides some, case reports. And so I think, something we're going to see more of for sure. I think the rectal is the place where it makes a lot of sense, though MSI high is pretty rare in rectal because it's almost always just Lynch patients. And so it's very infrequent to be a rectal with MSI high, but I think, it makes a lot of sense to have our best therapy being used, neoadjuvantly, right? And I think the 177 study, Pembro beat chemo, it kind of says that's our best therapy.
Is there any rationale for local administration in the case of rectum to try to avoid some side effects? I think with CTLA-4 it's a bit more tricky because I think a lot of it, in fact, comes from the systemic administration, but perhaps for the PD-1 blocking.
I actually think that it is very intriguing to look at some of these really powerful immune therapy agents and think about local administration, because there are a lot of great targets that you can't give systemically because they just, massively activate the immune system, right? So, which is kind of what you want, but you want it locally, So the idea of, I think for some of these novel agents is actually a really interesting, complicated, approach, but I think an approach that, is being explored, and we'll see probably some efforts there. In the neoadjuvant space, I just think toxicity is such a bigger issue, and kind of curative, resectable patients. And so for me, I think the problem with for me, neoadjuvant, I think PD-1 monotherapy it probably makes more sense in the path to go forward, just because of that toxicity side. But you're right. The idea of, local is an interesting one, and I think would potentially address that challenge, right? How do you give, your CTLA-4 but not cause the side effect profile? Maybe we just need to inject it. No, I think it's a great idea.
And I think we lost you there for a second, but I think you meant you said that the problem with the niche was that it went immediately for the combo and did not investigate the effect of single agent.
Correct. I think correct. Sorry about connection. I apologize,
No worries.
everyone. But yeah, I mean, just there's more toxicity, and I think when you go earlier stage, toxicity becomes a bigger concern. Yeah.
All right. Are there any questions from the
Well, no, let me ask you, what about, you've done a lot of work on kind of neoantigen kind of efforts. And so, there are efforts ongoing, looking at, personalized neoantigens, and I think the challenge there is, at least for microsatellite stable colorectal cancer, you have such personalization of your antigens, right? You don't have consistent antigens. And so, what do you think of the I guess, to be able to, to produce or manufacture, personalized kind of vaccines? And is that going to be a key component of any, combination kind of in the future, maybe? I mean, what is your thoughts on that kind of space?
Yeah, I mean, I think before trying to figure out what is the approach that is more feasible, we still need to come up with the best way to make use of the fact that we have T cells in patients that can recognize cancer antigens. I'm not absolutely convinced at the moment that vaccination is the best way to go. And I would like to see vaccination compared to other approaches, which are potentially technological a bit more complicated. So you could think of, if you can also identify the T cell receptor that is recognizing a specific neoantigen that is being presented in cancer cells, can you also generate an engineered T cell that is carrying that T cell receptor? But there again, it becomes even more complicated and more expensive. And as you said, there have been some reports, particularly from the Rosenberg's lab, where hotspot mutations like KRAS are being presented and can be recognized by immune cells. At least if we could start with those of identifying and manufacturing a few TCRs that we could use off the shelf for some mutations that might be more commonly presented, I think that would be a good way to go. I think for the vaccination setting, we still need to come up with the best strategy to vaccinate. It's interesting, though, that the technology that we're using now for the Pfizer vaccine, right, that was being developed to administer cancer antigens, and it works, right, to generate immunity. But there again, it might be the problem that it's much easier for our immune system to recognize an antigen that is derived from the virus and has nothing to do with our own proteins than targeting a cancer antigen with just a slight amino acid modification as compared to the germline. But we really need to come up with a good strategy to make use of those T cells we have circulating in our body.
Yeah, I mean, I think a lot of great potential. Right, I completely agree with you. The ability to do that now is something that's not science fiction, but reality. Right, it's complicated, but reality. It's but I think there's that other side of the immunosuppressive factors. Because generating a functional T cell, but that T cell has to get to the right location, has to last, has to survive, has to be functional, has to continue to kind of survive and replicate. And so I think there's all these other kind of aspects that are still, real challenges, I think. And colorectal is one of those ones that, is clearly kind of a player there, because the mutational load is not super high, not super low, but clearly based on mutational load, I think there's other players at hand. And I think, and so I do foresee a day where we have, kind of that aspect, and then kind of some other agents to address the microenvironment, and maybe we'll have a synergy of kind of, putting those two together and have real activity. But But I still think it's a lot of an understanding, and I think the factors that are really at play in the tumor microenvironment, I think, are complex, and we don't fully have a sense of that. Is my my
definitely.
sense of, yeah.
Yeah. So I think we can be rather confident that going forward, and in some years, we will have more CRC patients benefiting from different types of immunotherapy or strategies. But there are definitely some barriers to be overcome until we get there. I have one question, perhaps. I mean, there are a number of patients that do present with polymerase mutations, but not with MSE high. How are you dealing with those at the diagnostic level? Because you mentioned at the session that MSE testing should be offered, of course, to the patients to indicate the ones that can benefit. Are you doing in your center exome or whole genome sequence to come up with extra patients with a high number of mutations?
Yeah, I mean, we do next generation sequencing, and we have Epsilon on our panel, so we would capture it that way. Clearly, you're right. Yeah, I mean, you can have polymerase epsilon or polymerase delta 1 mutations that result in high mutation load that don't have to be microsatellite instability high. Really rare. Because I think you see it more commonly in earlier stage than again later stage. But yeah, no, definitely there's a lot of anecdotes out there. You feed those patients with immune therapy and they do fantastic. And so I think it gets back to, I think, the point of the next generation sequencing panels is really becoming more and more ingrained into what we need to be doing. I think you could get deficiency in mismatch repair by immunochemical staining, but you can also get it through an NGS panel, and I think that works really well in regards to identifying defect there. And in addition, you get some of these other mutations of interest, some standard RAS, NRAS, BRAF, and then you get the whole fusion space, right? There are these really rare fusions that we have great drugs for, and so you want to kind of capture those. And so I just think we're going more and more to like NGS becoming kind of a real standard approach, with these kind of larger panels. And so I think we will get some of these, rare events. And as you kind of have a bigger panel, the more rare events do kind of add up in numbers. It is challenging because they're so rare. I mean, because we're looking at fusion events in like a microsatellite stable colon cancer, the rate of event is probably like 0.1%. It's really, really low. And so it's a challenge to go after it unless you're kind of getting it as a byproduct of your, testing algorithm a little bit. There was one question in the chat about MRD space. Disease with circulating tumor DNA, and I think that I would agree with Annie. That's a really interesting area that a lot of effort in circulating tumor DNA as a biomarker for prognostic benefit, and then predictively we should be changing what we do in those patients. And I agree that I think even in the immune therapy setting, we find that as an interesting space, where you don't have that immune suppressive microenvironment that may be playing less of a role because you have kind of more limited cell numbers. And so I think an interesting may see some unique development. And I think one of the challenges with moving therapies to the adjuvant space or extra after surgical resection is just the numbers are just really tough. Like, so the atomic study MSI high is like an 800 patient study, and that's a lot of patients and a lot of effort to find those subsets. DNA, you can actually get a sense of activity level with a lot less number of patients. And so I think that space we find really interesting for kind of novel approaches for kind of clinical drug development, I would say.
Annie added a number of questions actually in the Q&A, and they're very interesting. And one of them actually focused on something that is very close to our interests as well, and whether you think MSS patients with homologous recombination defects, like BRCA mutations, which do occur in the minority of CRC patients, whether immune checkpoint inhibition should be considered for those, since it does show some activity as well, I think, in triple negative breast cancers with BRCA defects.
Yeah, no, I mean, definitely you can have of colon cancer that has, other DNA defects. I think in MSI high tumors, there's always so many mutations, it's always hard to know kind of what a driver is. So that's always a little bit of a challenge in those tumor types. And I think, immune therapy is standard anyway there. I think the microsatellite stable, when you have, some of these other DNA related defects, I think very interesting area for clinical trial investigation, whether immune therapy or even downstream kind of novel kind of agents that are targeting kind of those various pathways. Participators are kind of what everyone thinks about in regards to kind of approved therapies for kind of DNA repair kind of pathway alterations, but there's a lot of new, downstream ATR, ATM kind of related inhibitors that we have that I think are in clinical development and interesting. I think it's unclear to me that the rare patients with micro cancer that respond, I don't think we have a real good answer on what's driving that. And it is not necessarily clearly, they have a DNA repair defect that is kind of driving it. So I don't think that necessarily would be a clear biomarker for me to say, that patient should get immune therapy, though I think it's a clear biomarker for me to say, that'd be a really interesting thing to consider investigation in a clinical trial setting of various different kind of treatment options or approaches.
I had one question that relates more to the sporadic versus hereditary setting. I think one of the earlier papers suggested there was a difference in response to checkpoint blockade between sporadic and Lynch MSI cases. Is that signal still there? Is that something you see?
So I think so my sense on that a little bit is that, a Lynch patient is almost guaranteed that it's a MSI high tumor. Not always, but it's pretty close to guaranteed. Whereas in sporadic, I think there's a chance you don't have an MSI high tumor, and so I actually think the I think they really, from what we see in more data that's come in, that I think Lynch or non-Lynch, if you're MSI high and you're a true MSI high, your chance of response is really kind of the same. I don't really see any real distinction there a little bit. I do think that there, appears to be some data that the sporadic MSI are the ones where you see the higher fusion rate. So you don't see as much fusion in kind of the Lynch MSI highs, but it's more the sporadic where you see a higher fusion rate. So that seems to be the subset MSI high that appears to have a higher chance of having, fusions that are engageable as well. And so I think in MSI high tumors, I always recommend fusion. I think one could argue when to do it a little bit, but I think there is a real, the rate of fusions in MSI high tumors is kind of, 5-10%, which is a fairly decent rate for finding targets where we have, approved drugs for, with kind of NTRK fusions, for example.
Yeah, that's very interesting. Let me see if there are some more questions here. So there's one, some of the NED MZI patients I know are having long-term effects, arthritis in the joints, and one with adrenal insufficiency. Will there be RWD collected? I'm not really sure what RWD refers to, but Dr. Herman probably.
I think real world data.
Oh,
yeah. But I missed the beginning of that question. It was related to toxicity.
To long-term effects, yeah, and specifically the development of arthritis, and one with adrenal insufficiency. So maybe rheumatologic consequences of immune checkpoint inhibition.
Yeah, I mean, I think, we have a lot more experience, right? We're using a lot of immune therapies now across multiple different tumor types and large numbers and really large randomized phase 3 trials. And then I think in the general sense, immune therapy has been, positive and superior to chemotherapy in a lot of those settings, despite, real risk of toxicity. There's no doubt about that. I think in the majority of settings, it is manageable. I think the biggest issue from the clinical side is that, these toxicities, they do have to be managed and captured early. So you need to like identify it and start stop immune system from attacking whatever organ it's attacking. And so I think there's a big issue of communication between physician and patient, because catching them early really has a big bearing on how severe they become and how problematic they are. But I think it's just more of a side effect profile we have to deal with and be aware of. And I think there are, kind of collections of, rheumatologic kind of toxicities and manifestations and how to manage those. And I think we're moving towards getting a little more sophisticated. It's not all just steroids for everyone, but, could you use some other these, disease modifying agents that are kind of steroid sparing? I think there's some real interest with that. And we see that in colitis even. There's some great drugs for inflammatory bowel disease that we're now using for immune induced colitis and are working really well. And so I think we're getting better on the management side of toxicity. And so I don't see that as so much of a slowing us down in the immune therapy space. I do think go to a non-metastatic patient, there is a difference though in kind of that's toxicity profile, just because in the metastatic space, we don't have therapies that cure people for the most part. And so you have the downside is, cancer death. And so, you accept more toxicity in that space. Whereas in resectable setting, you can with surgery cure people. And so you want to increase that cure fraction, but you already have a path to cure. And so you want to be more cautious on the toxicity side. There's some, like I see about NRAS. I don't know how much I would kind of view NRAS as a unique entity outside of, we kind of, KRAS and NRAS are both, oncogenes that are functional and active within colorectal cancer and also indeed. They serve as biomarkers for anti-EGFR therapy. We've talked a little about there is some sense that RAS status may have a little less benefit from immune therapy, but I think that's not really been validated yet. I think we don't really have any NRAS kind of based targeting, approaches. I think there are some for KRAS that are emerging that are really interesting. There's these KRAS G12C related agents that can target that version of a KRAS mutation. And it's really one of the first times we're able to target RAS, which is a very common mutation or gene that gets mutated across tumor types. So I think a lot of excitement that we're going to get better and maybe have other specific mutations that we can target kind of in the RAS pathway.
All right, I think we need to head to the closing of this breakout section. I'll thank everyone that joined and thank Dr. Overman as well. It was very useful for me as well, and it was great meeting you. I think we can, in a conclusion note, say that there's definitely a promise for immunotherapy being able to benefit more and more CRC patients and early age onset CRC patients in the future. But there's still quite some work and research to be done.
Thanks, Noel, for leading us through the session, and thanks everyone for participating. Great questions, and good Friday to everyone.
Yeah, I'll see you soon. Bye-bye.